Welcome to week 4 for pharmacology for the advanced practice nurse. This week we're going to start talking about specific classes of drugs. We're going to start out with principles for prescribing anti-infectives. The emphasis of this unit is on the typical oral treatment for common primary care problems. But you must remember to consider each patient with an infection as an individual case. You must look at patterns of resistance and changes constantly and the guidelines for treatment. These are updated at least yearly. So you must keep this in mind when you're prescribing anti-infective drugs. So let's take a look at the most common terms and definitions associated with anti-infectives. What is an antibiotic? We all have used antibiotics and all have probably administered antibiotics to our patients, but what is the real definition? An antibiotic is a product of a living organism that kills or inhibits the growth of microorganisms. Compare this to antimicrobial, which is any naturally occurring or synthetic substance that kills or inhibits growth of microorganisms. So an antibiotic is something, a product of a living organism, whereas an antimicrobial is a naturally occurring or synthetic substance. Bacteriostatic is the ability to inhibit growth and replication of bacteria. This is the body's immune system, which is required to immobilize and kill the organism. Again, bactericidal is the ability to kill bacteria independent of the immune system. When we look at antibiotic effectiveness against an organism, it is determined by exposing the organism to various antibiotics. This is done in the lab. In vitro sensitivity tests are standardized to reflect the drug concentrations in plasma. They do not reflect concentrations that can be attained at the site of the infection, so you must keep this in mind that this is in the laboratory, not in the patient. They also do not take account into local factors that may affect the activity of the drug, for example, pH. So when we look at the effectiveness, the lab results come out with a MIC, or minimum inhibitory concentration. What this is the lowest concentration of an antimicrobial agent necessary to inhibit growth of an organism. We also look at the MBC, or minimum bactericidal concentration. This is the lowest concentration of an antimicrobial agent necessary to kill an organism. So when we look at these values, we try to look for the and prescribe the medication that gives the lowest concentration that will inhibit the growth or kill the organism. As we continue looking at different terms and definitions, remember that bacteria are one-cell organisms with a primitive nucleus and rigid cell walls. These are porous and permeable to substance of low molecular weight. Intracellular bacteria retain the ability to reside and replicate within cells. Examples of these are Salmonella, Legionella, Mycobacteria, and Chlamydia. The extracellular bacteria reside and replicate outside the cells. Examples of these are Streptococci and Staphylococci, most of the gram-negative enteric rods, and some of the Pseudomonas species. The gram-negative bacteria have a more complex cell wall than the gram-positive bacteria, and the bacteria are called gram-negative or gram-positive according to the results of laboratory gram stains. The difference in the cell walls is an important factor in the ability for the antibiotic to penetrate these cell walls of the bacteria and kill these bacteria. Another variable that's important in decision making, whether bacteria is aerobic or anaerobic. This is whether they need oxygen or they don't need oxygen. This trait will determine where in the body the organism will grow best and potentially cause infection. This is also very important when one's selecting appropriate antimicrobial therapy in the absence of culture results. If we know that the bacteria is anaerobic or aerobic, whether they need oxygen or not, this will help us determine what type of bacteria is commonly present in a specific area in the body. We also have to look at spectrum of activity. This refers to the specific organisms of classes of organisms for which antimicrobial agents is considered to be generally effective. You must keep in mind that this is related to geographic areas, because geographic differences in organism sensitivities depend on various factors, including prior and ongoing antimicrobial exposure. So in other words, this is going to depend on what type of resistance in a specific geographic area. One organism may be resistant in one area, it may not be resistant in another. So we look at the spectrum of activity. They are either narrow or broad spectrum. Narrow spectrum are effective against a limited number of organisms, unlikely to disrupt normal flora. Examples of these are gram-positive and gram-negative anaerobes. There's limited organisms that the organism has a very narrow spectrum of what it is effective against. Whereas broad spectrum antibiotics, these are effective against multiple organisms from more than a single class, gram-positive and gram-negative anaerobes. So what are gram-positive and gram-negative anaerobes, or gram-positive and gram-negative bacteria? By knowing whether a bacteria is gram-positive or gram-negative, it helps us choose an antibiotic that's effective against a specific organism. We determine whether they're gram-negative or gram-positive by the gram stain. The gram stain reflects basic differences in the cell wall composition. A gram-positive organism retains a red staining dye in the lab and appears to be deep violet under the microscope. These cell walls are low in lipids, whereas gram-negatives, on the other hand, do not retain a red staining dye in the laboratory and appear red in the microscope. These cell walls are high in lipids. Many, but not all, anti-infectives exert their effects on the cell walls. So cell wall differences determine whether certain anti-infectives will be effective, but not all. Anaerobes are organisms that can grow in the absence of oxygen. This characteristic allows them to grow in necrotic tissue and are poorly aerated portions of the respiratory tract. Because they don't need the oxygen, and in necrotic tissue, oxygen is not available. Mycobacteria, such as the TB organisms, do not gram stain. They have very tough cell walls and are difficult to kill. Yeasts are gram-positives, and rickets are gram-negative. So again, many antibiotics exert their effects through actions of the cell wall. The cell wall differences determines whether certain antibiotics will be effective. We also have to look at patterns of resistance. Again, they differ from one community to the next, and it's always changing rapidly. It depends, again, on what antibiotics is frequently used in that specific community, whether the bacteria develops a resistance to that antibiotic. You must also consider patient's exposure and what the patient's treatment behavior has been. What type of antibiotics has this patient been on in the past? Has the patient continued to take the antibiotic for the full course, or did they just take a few days when they felt better? It's very important for the clinicians to pay attention to the organisms that are dominant in the community and know the local disease pattern. Patterns of resistance differ from one community to the next, and they change rapidly. The CDC has an active program that educates clinicians about patients about drug resistance. These include fact sheets and discussion about antibiotics and how to preserve antibiotics for the future. And this can be found on the CDC website. It's important to culture and identify the organism when possible. This will help to prevent resistance and be able to treat more specifically for that particular bacteria. And monitor culture results and share this information with your colleagues. If you know that you've been treating specific bacteria with a specific antibiotic and it's built up resistance, share this with one another. Many hospitals develop biograms in which they look at specific bacteria and the treatments and the resistance, and they print these out and dispense them amongst clinicians. So that's a very good source of finding out what your resistance is in your particular facility. So what are the mechanisms of resistance? Well, many of the bacteria acquire specific genes, efflux pumps, several genes, or through transformation, conjugation, and or transduction. Among all types of healthcare providers, anti-infectives rank the most frequently prescribed products. And although their efficiency is decreasing, mortality and morbidity is unquestioned. So that the overuse and abuse of these products have led to drug resistance. The bacteria can acquire genes that produce enzymes that inactivate the antimicrobial agent. Common drug resistance producing enzymes are collectively known as the penicillinases. These are enzymes that inactivate the antibiotic, and these are most prevalent in the beta-lactamase. The bacteria can also acquire efflux pumps, and these are capable of draining the antimicrobial agent from the bacterial cell prior to any bactericidal or bacteriostatic effects. Such efflux pumps can cause multi-drug resistance, such as the methicillin-resistant Staphylococcus aureus, which is MRSA, or resistance to tetracycline due to active efflux. Bacteria can acquire several genes capable of eliminating the antimicrobial binding site during synthesis of the bacterial cell wall. And mutations can occur in the gene that encodes the target protein so that no longer it can bind to the drug. These are random events that confer a selective advantage for the bacteria, and this mechanism does not require exposure to a particular drug. It can occur in a single-step mutation that develops a high degree of resistance, or it may be seen in a several-step mutation in which each step exhibits a slight alteration in susceptibility. So over time, the antibiotics become less effective and more resistant. Examples of resistance through mutation include the Mycobacterium tuberculosis, E. coli, and Staph aureus. Resistance also occurs through bacterial mutation via transformation, conjugation, and or transduction, with the resultant mutated form resistant to one or more class of antibiotics. Transduction occurs when a virus that contains a DNA infects the bacteria. The virus that infects the bacteria contains plasmids of bacterial DNA that contains genes for various functions, including one that provides drug resistance. The incorporation of this plasmid makes the newly infected bacterial cell resistant and capable of passing on this trait of resistance. So once one bacteria is resistant, then it can transfer this through replication. The plasmid carries the code for penicillinase. An example is Staph aureus. Other contain codes for resistance to erythromycin, tetracycline, and chloramphenicol. Transformation involves transfer of DNA that is free in the environment into the bacteria. Examples of this include penicillin resistance in pneumococci and Neisseria. Conjugation is a transfer of DNA from one organism to another during mating. This occurs predominantly among gram-negative bacilli, such as Enterobacter and Shigella flexunaria. These factors over time cause decreased penetration of the target cell, alteration of the target site, and inactivation of the antibiotic by a bacterial enzyme that causes bacterial resistance. Antimicrobials are becoming less effective because of the exchange of genetic material, selection pressure, and mutations over time among the pathogens. Concurrently, the total number of new antimicrobial agents underdeveloped is decreasing, and this is because of the resistance that is building up. So why is this important? It's very important that we know this because as clinicians, you can explain this to patients. Every time a person takes an antibiotic, sensitive bacteria are killed, but resistant germs may be left to grow and multiply. Repeated and improper use of the antibiotics increase the risk of drug-resistant bacteria, as well as misuse. Misuse of antibiotics jeopardize the usefulness of essential drugs. So it's our job to decrease the inappropriate antibiotic use in order to control resistance. If we can explain this to our patients, every time they come to the office, they might not expect you to write a prescription for an antibiotic for a sore throat. So again, let's look at the mechanism of action of anti-infectives. They are classified as either bacteriostatic or bactericidal in action. Again, bacteriostatic agents inhibit growth. Bactericidal agents kill bacteria. Anti-infectives provide these effects through different mechanisms of action. This includes inhibition of cell wall synthesis, especially true for the beta-lactam anti-infectives such as penicillin, cephalosporins, etc., vancomycin, antifungal agents as well, and bacitracin. They also have direct action on the cell membrane that alters permeability and can cause leakage of intracellular components or compounds. Example of this is the bactericidal action of polymyxin and nystatin. They can also affect the function of ribosomal subunits that inhibit protein synthesis. Examples of this are the bacteriostatic actions of tetracycline, erythromycin, clindamycin, and chloramphenicol. They may also bind ribosome subunits to alter protein synthesis and cause cell death. Examples of this include the bactericidal action of aminoglycosides. They also block specific essential metabolic steps. For example, the bactericidal actions of sulfa drugs and trimethoprim. And finally, inhibition of viral enzymes essential for DNA synthesis through the nucleic acid analogs that produce bactericidal activity. These are the many mechanisms of actions, either bacteriostatic or bactericidal. So with all these resistance and mechanisms of actions, how do we treat? How do we choose the appropriate antibiotic? Well, we must choose the most cost-effective antibiotic with the narrowest spectrum, lowest toxicity, and lowest potential for allergy to decrease the risk of resistance while being cost-effective. We must consider both the drug characteristics as well as the patient characteristics when choosing an antibiotic. We must only treat if a bacterial infection is present. Many times patients will come into the office with a sore throat and they're set on the fact that they have a strep throat and need an antibiotic. But we need to ensure that a bacterial infection is present so that we don't build up this resistance and don't treat unnecessary infections. We need to keep in mind that antibacterials tend to alter the normal flora, and normal flora help prevent overgrowth and infection by pathogenic bacteria. Change in flora in this flora places the patient at risk for superinfection, especially with yeast. The wider spectrum antibacterial is that we choose, the greater there's an alteration in the normal flora and the greater risk of superinfection. A perfect example of this is C. diff colitis. We kill off the normal bacteria and the C. diff colitis takes over. We choose an antibiotic with a narrow spectrum that is effective against the organism causing the infection. We must choose antibiotics that have the lowest toxicity and least potential for allergies in the patient. And again, most cost effective. We also need to think about prophylaxis. The emphasis should be on prevention of bacterial infections. In some occasions, however, prophylaxis is indicated. If a single effective non-toxic drug can be used to prevent an infection by a specific organism or get rid of the organism immediately after it's been introduced, then prophylaxis is what we call successful. It's often not successful in preventing colonization or infection by microorganisms present in the environment. An example of traditional use of prophylaxis is used in the prevention of bacterial endocarditis by group A streptococcus. However, this has been challenged in many studies. This is when we treat prophylactically when a patient is at risk for endocarditis when they're having dental procedures. Treatment for a sexually transmitted disease after exposure is often effective. And this is when patients are present after they've had sexual activity with a known positive carrier of sexually transmitted disease and are treated with an antiviral medications. Attempts are being made to provide prophylaxis for HIV post-exposure. Immunizations, when indicated, such as for flu or hepatitis B or HIV, and treatment for positive skin tests for tuberculosis are also examples of prophylaxis. Prophylaxis is sometimes attempted for patients at increased risk for bacterial infections, such as those undergoing organ transplantation, cancer, chemotherapy, and HIV treatment. However, prophylactic treatment also kills many of the normal flora of the host and allow other infections to occur with drug-resistant strains. So it defeats the purpose of prophylaxis and puts these patients at risk for other infections. Clinical guidelines are developed for the treatment of many of the common infections. You can find many of these guidelines. They're developed as a result of analysis of valid research and scientific studies, and have been issued by federal agencies and professional groups. You can find these on the internet. You can go to specific websites. You can go to the CDC. And it's important to administer antibiotics according to the accepted guidelines, because these have been tested. You always should establish a definite duration of treatment, and do not begin an open-ended course of antibiotic treatment. If necessary, the course of therapy can be extended if the patient needs continuation beyond the originally defined period, but plan on stopping at a specific time so that you don't build up resistance. And whether to discontinue a course of anti-infectives can be difficult to decide. If the culture shows that a bacteria are resistant to an agent currently that's in use, then it's clear that you must discontinue the drug and substitute one which the bacteria is susceptible, if the patient is still ill. In general, providers should emphasize to the patients that it's important to complete the whole course of anti-infectives, even if the symptoms are gone. This is necessary to completely get rid of the offending organism, not just the ones susceptible to the antibiotic, while leaving resistant bacterial alive. On the other hand, you should discontinue an antibiotic that was started based on empirical evidence if the culture is negative. Many providers are reluctant to do this for a variety of reasons. Again, patient expects to be treated with an antibiotic, and they feel that this will make them better even though their culture came back negative. This is true for strep throats, true for ear infections, also true for the common cold. Many patients expect to come in and get treated with an antibiotic, and if you think that there might be a bacterial component to this, you start them on antibiotics, and when culture comes back for the sputum that's negative or throat, then the patient needs to stop the antibiotics so that the resistance won't prevail. Many of the skin, eye, and vaginal infections can be treated local application of medications. Drainage of a site, for example, in some sinus infections and an empyema is necessary. Abscesses must be drained. You cannot treat with antibiotics if the abscess is still there. Anti-infectives do not replace local treatment, such as incision and drainage. A lot of times we drain the abscess and the patient doesn't even need antibiotics. It clears up on its own. Foreign objects must be removed to prevent infection. Again, the most important complication of antibiotic treatment is superinfection by the organism that is resistant to antibiotics. This can be caused by bacteria, for example in colitis. Again, C. diff colitis. Fungal infections can also be a problem. For example, women frequently get vaginal yeast infections when treating with an antibiotic because you're killing off the normal bacteria that is present to prevent yeast from growing. So how do we classify aerobic pathogens? We have gram-positive cocci, which are aerobic. They retain the initial stain in the lab and are blue-purple in color under the microscope. These include the Staphylococcus aureus, S. epididymitis, Staphylococcus pneumonia, Group A beta hemolytic strep, Group B, and Group D. We also have the gram-negative bacilli. These are aerobic. These include the bacillus species and dipteroids. These resist initial stain and take on a color of the red-pink counterstain in the laboratory. We also have the gram-negative bacilli. This includes the Haemophilus influenza, the Campylobacter species, the H. pylori, and the Legionella. And gram-negative cocci. These include the Enterobacter species, E. coli, Klebsiella species, Proteus, Salmonella, Shigella, and the non-lactase fermenters, such as Pseudomonas. For the anaerobics, these include the gram-positive cocci, the Peptostreptococcus species, the gram-positive bacilli, Clostridium species, and the gram-negative bacilli, bacteroides, Fragilis. I don't expect that you're going to memorize all these gram-positives and gram-negatives, anaerobic versus aerobic, but make yourself a chart that you can separate these. I believe there are some great charts in the book, as well as I've provided some links to antibiotics and their mechanisms, as well as gram-positive, gram-negative bacteria. Classification again of common pathogens. There's chlamydia, chlamydia trachomonas, C. pneumonia, C. pistachii, and the mycoplasmas. The mycoplasma pneumonia, these are not a true bacterium because they lack a cell wall. We also have the spirochetes and the fungi. So let's start and take a quick look at treatment for specific infections and miscellaneous antibiotics. We'll go into this a little more detail in the next section. So some of the specific antibiotics not in the general classes include clindamycin, the vancomycins, the nitrofurantoin, and miscellaneous phosphomycin. These are specific classes that are not in the most common classes. So what are the treatment principles? Guideline, for example, for skin and soft tissue infections, guidelines are provided by the Infectious Disease Society of America, and they look at specific infections and look at what the most common bacteria as well is, as well as what is the most effective treatment. For example, cellulitis. Most cellulitis is seen in the primary care, is easily treated, but the provider must rule out following complicated patients for whom they seek referral. So for most of the cellulitis, group A strep is usually present. Occasionally there's a group B or C or G strep or Streptococcus pyogenes. Staph aureus is also present and often uncommon. However, we're seeing a greater number of these methyl-resistant Staph aureus in wounds and cellulitis. There's also the necrotizing fasciitis, which is commonly known as flesh-eating bacteria. These are usually polymicrobic with gram-positive and gram-negatives, as well as anaerobics, group A, C, and group G streps, enterococci, staphylococci, E. coli, Pseudomonas, Proteus, Clostridium. It can be a number of microbes, and these patients usually require hospitalization. And the diabetic patients, they often found to have group A strep, Staph aureus, and Enterobacter. Clostridia is also present, but often is rare in these patients. These patients often are complicated because of their diabetes and require hospitalization. Usually treatment for diabetic patients with cellulitis is at least 3 days after resolution of inflammation. You need to maintain very strict glucose control in these patients. Staph aureus remains a possibility and should always be considered if first-line treatment is not successful. Always keeping in the back of your mind a meth-resistant Staph aureus. We look at animal bites. These cats, Pasteurella and Staph aureus. In dogs, Staph aureus, the bacteroids species as well. And human bites, the Streptococcus viridians, Staphylococcus epidermidis, Cornbacterium, Staph aureus, Bacteroid species, and Peptostreptococcus. The location and type of wound are important factors, as is the type of animal and selection of appropriate treatment for the bite wound. Unprovoked animal bite should raise the suspicion of rabies, and a patient should be treated post-exposure. Cat bites are most likely to become infected, more so than human or dog bites. Human bites by children are not likely to become infected. Infection is most likely to occur when adults are with bites by adults. Usually dog bites are unlikely to become infected, but many of these bites should be left open so that they drain, so that if there's any bacteria present, it doesn't get stuck in a closed wound. These patients need to be given tetanus and diphtheria booster if not vaccinated within previous 5 years. Again, don't suture or glue the wound closed if it's been longer than 12 hours since the bite occurred, or in general, we don't like to close bite wounds, especially if the injury is a hand wound or a cat bite. Prophylaxis is recommended for bites on the hand or in the genital region, for human or cat bites, for crush and puncture wounds, and for the treatment of patients with impaired immune systems. We also need to consider infected postoperative wounds. These wounds usually grow out Staph aureus, a group A streptococci, or enterobacteria. Superficial infected wounds usually are treated by the primary care physician. However, if the infection is deeper, the treatment selected will depend on the type of surgery and should be referred back to the surgeon. When we look at respiratory tract infections, most common causative agent is a virus, which causes an acute self-limiting disease that should not be treated with antibiotic. For the otitis media, the most common bacteria is strep pneumonia, Haemophilus influenza, Moraxella catarrhalis. Viruses, group A, strep, Staph aureus, and Enterobacter. And the Enterobacter is uncommon. Usually treatment for the otitis media is generally 10 days. Signs and symptoms that indicate the need for antibiotic treatment for otitis media include otalgia, fever, otorrhea, or bulging yellow or red tympanic membranes. Simple effusions or the presence of fluid in the middle ear with no signs and symptoms of an acute infection does not need to be treated with antibiotics. Patients with tympanic membrane perforation, chronic or recurrent infection, craniofacial abnormalities, or immune compromise should be referred to an ENT for treatment. The reason being that you don't want to continue to treat with antibiotics and build up resistance. How recently the patient has been treated with antibiotics will also affect your antibiotic choice. For sinusitis, acute sinusitis, these most often are again the strep pneumonia, Haemophilus influenza, and Moraxella catarrhalis, same as the otitis. Less frequently, you find the group A strep, anaerobe, Staph aureus, Streptococcus species, and Neisseria species, as well as gram-negative rods. For chronic sinusitis, these are mostly the anaerobic bacteria, the bacteroids, the Streptococcus, and the treatment duration is usually 10 to 14 days. When antibiotics are used for the sinusitis, guidelines suggest augmentin or amoxicillin with clavulanic acid instead of the amoxicillin alone. Evidence of bacterial infections include prolonged symptoms with no improvement for 10 to 14 days or longer, fever higher than 102 degrees Fahrenheit or 39 degrees Celsius, unilateral pain, sinus tenderness, or tooth pain. Nasal discharge is not a reliable indicator of bacterial sinusitis. As with viral URIs, the nasal discharge may change from clear to yellow during the first few days of infection. You should only suspect a bacterial infection if the discharge changes to green. If the patient starts to improve and then worsen, this may indicate that a secondary bacterial infection may be present. Decongestants and mucolytics may improve the drainage. Non-pharmacological remedies such as drinking hot fluids, applying moist heat, inhaling steam, using saltwater nasal sprays or rinses may decrease congestion and symptoms. Research is mixed on the effectiveness of normal saline rinses. Pharyngitis is another common infection that you'll see, and the pharyngitis bacteria mostly include the group A, C, and G strep, Corynebacterium, diphtheria, Mycoplasma pneumonia, and duration of treatment is usually at least 10 days. Viruses such as mononucleosis can cause pharyngitis. The classic infection to be treated with antibiotics is the group beta hemolytic strep. It's extremely difficult to diagnose bacterial pharyngitis by history and physical alone. A throat culture is necessary. Symptoms such as pharyngeal pain, dysphagia, fever, tonsillar exudate, and lymphadenopathy with absence of cough increases the likelihood of a diagnosis of strep, but only can you make accurate diagnosis by culture. Approximately 1/2 of patients with these symptoms will have strep throat on culture. In areas where there's increased resistance to penicillin, an oral cephalosporin is more likely to be effective than a penicillin alone. Again, culture is very important to identify whether this is a bacterial versus viral pharyngitis. Bronchitis is another very common ailment that you'll see in practice. And viruses cause most cases of bronchitis. In infants and children less than 5, virus is the usual cause. Adolescents and adults, you'll see viruses, pneumonia, chlamydia pneumonia, and Bordetella pertussis. With acute bacterial exacerbation of COPD, you'll see many of these patients with a Streptococcus pneumonia, an H. influenza, and an M. catarrhalis. Mycoplasma or chlamydia are rare. Many of the acute exacerbations of COPD are viral. However, patients may have one of a wide variety of bacteria depending on previous hospitalizations and illness. These patients are likely to be frail, have a smoking history, and have been previously treated with antibiotics. These are the patients that are probably in need of antibiotic treatment. However, again, you need to watch for resistance because these are the patients that are most likely to have resistance due to their previously treated illness. The community-acquired pneumonia, usually ages 1 to 3 months. It's a chlamydia, RSV, or respiratory syncytial virus, or Bordetella. Ages 1 to 24 months. Again, the RSV, bronchiolitis. You'll see viruses, strep pneumonia, H. influenza, chlamydia, mycoplasma, and Staph aureus, which is very rare. In ages 3 months to 5 years, again, many viruses, strep pneumonia and mycoplasma chlamydia are the most common agents. Ages 5 to 18 years, you'll see the mycoplasma, the respiratory viruses. You should, in this age group, consider strep pneumonia and chlamydia. Ages 18 years and older, with no comorbidity, you want to consider the mycoplasma, the chlamydia, the strep pneumonia, the Staph aureus, your group A streptococcus, Mortadella catarrhalis, anaerobes, aerobic grams, and bacterial or viral. In smokers, you want to think about strep pneumonia, Haemophilus influenza, and Mortadella catarrhalis. Post-viral pneumonias, you want to think about strep pneumonia. Rarely do you see Staph aureus. In the alcoholic patient, you need to think about strep pneumonia, anaerobes, and coliforms. And if you're seeing an epidemic, you might want to think about Legionnaire's disease. Treatment of the pneumonia usually lasts until the patient is afebrile for at least 5 days, or pneumococcal pneumonia, often 10 to 14 days. Pneumonia is usually caused by the enterobacteria, Pseudomonas or Staphylococcus, and these are treated for 21 to 28 days. Because there are so many different bacteria that can cause pneumonia, depending on the empirical treatment, this can be problematic. The mycoplasma and the chlamydial infections are common, and macrolides in these cases are recommended. However, penicillin-resistant pneumococci occur regularly and may be resistant to the macrolides or doxycycline. The frail elderly may require treatment with the fluoroquinolones, but again, we're seeing increasing resistance with these medications, so you need to really consider what type of bacteria would be causing these pneumonias. You should go to the IDSA website. There are guidelines for community-acquired pneumonia. Again, the IDSA is the Infectious Disease Society of America. So prophylactic regimens for dental, oral, respiratory tract, or esophageal procedures. These regimens are performed for patients with risk for endocarditis or prosthetic devices such as valves, knees, hips, and shoulder replacements. For GI infections, you want to think about the mouth. Mouth infections can be caused by a large variety of bacteria, but they often respond to penicillin. Because uncontaminated cultures are difficult to obtain from the mouth, treatment with a broad-spectrum antibiotic is usually necessary. We treat mostly for the Streptococcus species, the oral microflora, and infection often with polymicrobial. Usually treatment duration is 2 to 3 weeks. For gastroenteritis, mild forms, you want to think of viruses, bacterial or parasitic, and most diarrhea is viral in cause, not severe and self-limiting. Traveler's diarrhea, for acute, you need to look at the area that the patient has been traveling, but acute causes are either E. coli, Shigella, Salmonella, Campylobacter, Clostridium difficile, and amblyopiosis. Chronic traveler's diarrhea is often caused by Cyclosporia, Cryptosporidium, and Giardia. Duration of treatment for these cases for the acute diarrhea is usually 3 days. If a patient is traveling to an area with an epidemic infection and you may be unable to observe safety precautions such as drinking bottled water, a course of antibiotics may be provided so that the patient is able to initiate treatment immediately as soon as onset of symptoms occur. Treatment may also include loperamide and or Pepto-Bismol. However, if these are bacterial, you really don't want to bind the patient up. A transcutaneous immunization with a heat-liable toxin in a patch in 2 doses taken 2 to 3 weeks apart prior to travel has been tested to protect individuals against E. coli traveler's diarrhea. I'm not sure how often this is prescribed. For severe diarrhea, the most causative agents include Shigella, Salmonella, Campylobacter, E. coli, C. diff, Entamoeba, Histolytica, and many others. Duration of treatment of these are 7 to 14 days. Symptoms of severe diarrhea include more than 6 liquid stools per day, a temperature greater than 101 degrees Fahrenheit, blood and fecal leukocytes. Patients always require a stool for fecal leukocytes in culture, and treatment is based on these culture results. You don't want to treat a patient with antibiotics if they have C. diff colitis, because that will make it worse. Again, C. diff colitis is often a consequence of treatment with all antibiotics. The most likely culprits are 4 antibiotics for C. diff infection include ampicillin, amoxicillin, cephalosporin, and clindamycin. If you notice, these are the most common antibiotics prescribed. And this is why we're seeing such an incidence in infection. The incidence of infection is high with these drugs because of their widespread use, especially in children. The fluoroquinolones are also implicated in C. diff colitis, associated diarrhea, again because of the widespread use. Tetracycline use is the least likely to cause the problem. However, this is not used in children. The presentation of C. diff varies from mild illness to rapid clinical deterioration. There's also different strains of C. diff colitis, which can be severe. It's often associated with copious amounts of liquid diarrhea. However, it can be less acute in onset and moderate in amount of liquid stool produced. If you suspect C. diff in any patient who develops diarrhea after taking an antibiotic. However, if a patient has copious amounts of liquid diarrhea and has not been on an antibiotic, you still should test. The onset of symptoms can be delayed for weeks after treatment with an antibiotic, and because of the potential for severe symptoms, you should treat promptly. Treatment for C. diff is Flagyl, 500 milligrams of PO 3 times daily for 10 days for mild to moderate infection. More infection is treated with vancomycin, 125 milligrams PO 4 times daily for 10 days. The IV use of vanco as well as Flagyl is not as effective. For treatment of diverticulitis, the bacteria most likely to cause infection is Enterobacter, Pseudomonas, and bacteroids, as well as Enterococci. The treatment is provided until the patient is afebrile for at least 3 days. Symptoms of diverticulitis include acute abdominal pain and fever, left lower quadrant abdominal tenderness and mass, and leukocytosis. Severity ranges widely from mild to severe disease, and treatment requires a broad-spectrum oral antibiotic with anaerobic activity. Many of the treatment in the past has been a combination of Levaquin and Flagyl, but it needs to be broad-spectrum with anaerobic activity. And finally, peptic ulcer disease. The likely cause of this is H. pylori. And this is treated with a Prevpac in many cases, and includes antibiotics as well as other medications. You can look this up on Hippocrates or up to date for the current guidelines. These change often, so it's very important to continue to look at these sites, look at the evidence-based information, and treat appropriately. For the renal GU infections, most common urinary tract infections, we'll see this both inpatient and outpatients, as well as pyelonephritis. Most common agents are E. coli, Proteus mirabilis, Pseudomonas, Klebsiella pneumonia, Enterobacter, Staphylococcus, Enterococci, and many others. Duration of treatment for an uncomplicated UTI is usually 3 to 10 days. In general, a single dose treatments are minimally effective in resolving UTIs. However, it has been tested. Most commonly is treatment for 3 days in uncomplicated UTIs. For pyelonephritis, treatment is at least 14 days. Most resources state that a urine culture is not necessary for the management of a simple UTI, and a clean catch urine specimen is the most commonly used diagnostic test. With urine dipstick testing, the presence of nitrates has a specificity of more than 90% to diagnose a UTI, but sensitivity is only 25%. Leukocyte esterase may also be found in the urine dipstick with UTIs. Pyuria is more sensitive and less specific than other dipstick readings, although less sensitive for UTIs in pregnancies. When a urine gram stain confirms bacteria, a sensitivity and specificity of 80 to 90% for UTIs respectively is found. In cases of complicated or recurrent infection, a urine culture needs to be obtained. Although the presence of 10 to the 5th colony forming units per mil or more on culture is considered diagnostic for a UTI, nearly half the women with 102 to 104 colony forming units have symptoms of UTIs. An acute uncomplicated UTI can be treated empirically with any of several antibiotics available. Non-pharmacological interventions include rest, hydration to flush the urinary tract, short-term use of urinary analgesics with agents with phenylzaropyridine and uress. It's been suggested by limited research that cranberry juice or its extract may reduce bacterial adherence and protect against developing cystitis. Patients with complicated UTIs often require more intensive antibiotic therapy, including long-term prophylaxis, post-coital treatment, or self-start treatment. A goal is always to prevent progression to pyelonephritis, particularly in those pregnant women. Some frequently prescribed, you also need to look at some of the frequently prescribed antibiotics damage the normal vaginal flora. And this is why we see yeast vaginitis developing in 25% of our patients, especially treated with ampicillin, and 80% of those who take tetracycline. Initial treatment for uncomplicated UTI is a 3-day course of trimethoprim sulfa or Bactrim. This may be given to women with uncomplicated UTIs. Fluoroquinolones and nitrofurantoin are second-line antibiotics. When given for 7 days, the nitrofurantoin is more effective than a 3-day dose of Bactrim. Ciprofloxacin and Bactrim are becoming less effective against the germs that cause most of the UTIs. So again, we're seeing resistance. While new guidelines have not been issued, this suggested that UTI patients without kidney insufficiency should be given nitrofurantoin, and the rest should take amoxicillin, clavulanic acid, and third-generation cephalosporins to prevent the resistance. Fluoroquinolones are widely used to treat UTIs. but are inappropriate in adolescents younger than 18 years or during pregnancy. Nitrofurantoin is highly effective against many gram-positive and gram-negative bacteria, including the E. coli, which is most common, and this is generally well tolerated with little significant effects on vaginal flora. This, however, must be given for 7 days. It is inactive against most Proteus and some Enterobacter and some Klebsiella. Ciprofloxacin and other quinolone derivatives are highly effective for the gram-negative bacteria and have good coverage against the Pseudomonas and gram-positive bacteria. These drugs are expensive and are contraindicated in pregnant or nursing women or anyone under 18 years of age. Recurrent UTIs are defined as 3 culture documented infections in a year, or at least 2 UTIs in 6 months. A continuous prophylaxis is recommended for at least 6 months for recurrent UTIs, and nightly dosing of Neurontin 100 milligrams, cephalexin 250 milligrams, or Bactrim 1 tablet is suggested. For women who frequently get a UTI after intercourse, postcoital prophylaxis with an antibiotic may be helpful. But again, you need to think about resistance. The other common infection that that's often treated is prostatitis. Men with prostatitis, usually younger than 35 years of age, consider gonorrhea or trichomonas and look for STDs. For older men, it's likely caused by Enterobacter. Other possible organisms include Enterococci or Pseudomonas. The first-line treatment for prostatitis consists of 160 milligrams Bactrim BID. Treatment may be required for at least 1 month. The problem may not resolve and prostatitis may become chronic. For chronic prostatitis includes fluoroquinolones. Duration of treatment can be as long as 4 to 12 weeks. For the sexually transmitted diseases, we're seeing patterns of resistance to STDs. Treatment recommendations are changing frequently. The best information will be from the CDC or other state resources before treating. The local health department is also a good source for information for the local patterns of resistance and effective treatments. Many patients who present with STDs will have other STDs as well. When gonorrhea or urethritis cervicitis is diagnosed, to treat for both gonorrhea and chlamydia. Concurrent treatment for syphilis also should be considered when signs indicate a possible presence of the organism. When a woman is diagnosed with a sexually transmitted infection such as chlamydia or gonorrhea, new guidelines from the American College of Obstetricians and Gynecologists recommend that clinicians should pass along a prescription of the antibiotics to the male partner. This is called expedited partner therapy. This is to prevent reinfection. For gonorrhea, patients infected are frequently or co-infected with trichomonas, and this has led to the recommendations of patients being treated for gonorrhea infection as well as against uncomplicated genital trichomonas infection. Men with urethritis and purulent discharge usually present, women usually have no symptoms but may present with cervicitis. Newborn infants can get the gonococcal infection in their eyes because this infection can cause blindness. Most state requires treatment at birth, and laboratory testing consists of grand staining of secretions and culture. We are seeing the quinolone resistant in gonorrhea. This is very common in Europe and Middle East, Asia, and Pacific. Resistance is also becoming increasingly common in the United States. For this reason, quinolones are no longer being recommended. For patients with uncomplicated genital, rectal, and pharyngeal gonorrhea, the CDC recommends recommendations call for combination therapy of ceftriaxone, 250 milligrams as a single intramuscular dose, plus either azithromycin 1 gram orally in a single dose, or doxycycline 100 milligrams twice a day for 7 days. CBC also recommends a test of cure 1 week after treatment for all patients. Again, very important to look at the CDC sites because these recommendations change frequently. For neonatorium, one of the recommended preparations is erythromycin 0.5% ophthalmic ointment installed in both eyes of every neonate once as soon as possible after delivery. It's not really known whether this prevents chlamydia, but is recommended. Syphilis is another disease, STD, in which is becoming prevalent. Again, syphilis is a systemic disease, and primary infection consists of an ulcer or canker at the infection site. Secondary infections include skin rash, mucocutaneous lesions, and lymphadenopathy. Tertiary infections, syphilis consists of cardiac, ophthalmic, and auditory abnormalities, as well as lesions. Latent syphilis lacks clinical manifestations. Dark field examinations and direct fluorescent antibody tests of lesions, exudate, or tissues are the definitive methods for diagnosing early syphilis. Chlamydia is another STD. Men present with urethritis or mucopurulent or purulent discharge. Women present with mucopurulent cervicitis. Untreated infection can result in pelvic inflammatory disease, ectopic pregnancies, or infertility. Because treatment of chlamydia costs less than diagnostic testing, many providers often decide to treat patients for gonorrhea as well as chlamydia without testing. The other STDs we often see are chlamydial genital infections, infant pneumonia, chlamydia trichomonas, cancroid, and Haemophilus. We're also seeing a great increase in HPV, human papillovirus, in which now there's immunizations for. Another treatment for female consideration should be female reproductive infections. Mastitis is very common and usually begins within 3 months of delivery, possibly it starts with a sore nipple. Symptoms of cellulitis become obvious. Symptomatic treatment includes applying cold compresses. Acute outpatients, most common bacteria are Staph aureus, strep pneumonia, strep pyogenes, Haemophilus influenza, and Pseudomonas. Vaginitis, very common in women. You see a lot of Candida, Trichomonas, and Gardnerella. These are the most frequent causes of bacterial vaginitis, vaginal discharge, or vulvar itching and irritation. Gonorrhea can also be a cause of vaginal discharge. Trichomonas and gonorrhea are generally transmitted sexually. Candida albicans and Gardnerella, most common causes of bacterial vaginosis, are not. For the Candida infections, Candida causes fungal infections of the vagina, which commonly are referred to as yeast infections. For a patient who has recurrent or chronic Candida infection, should be assessed for risk factors such as diabetes or HIV infection. Guidelines, again, are available from the Infectious Disease Society of America. It is safe and effective for a patient to use over-the-counter preparations without being examined by a healthcare provider if she is previously given a diagnosis of Candida infection and having the same symptoms. Fluconazole tablets take about 2 to 3 days to start working. Oral treatment may be given if the patient has aversion to vaginal products or if she is about to start her menstrual period. In general, the patient should be examined before the oral medication is prescribed. The oral formulation may be used in conjunction with an azole or hydrocortisone cream for more immediate relief of symptoms. Bacterial vaginosis, very common, occurs as an overgrowth of one or more bacteria, and this is not sexually transmitted. Often the predominant organism is Gardnerella, and symptoms include a grayish, sometimes frothy, fishy smelling discharge. Vulvitis or vaginitis may be present. On saline wet mount, epithelial cells are covered with bacteria to such an extent that the cell borders are obscured and called clue cells. Vaginal cultures generally are not helpful, but a clinical diagnosis of bacterial vaginosis is defined by the presence of homogeneous vaginal discharge that has a pH greater than 4.5, emits a fishy amine odor when mixed with 10% KOH solution, and contains clue cells on the microscopic examination. On laboratory exam, a gram stain of vaginal secretions diagnostic for bacterial vaginosis will show markedly reduced or absent lactobacillus morphology, predominance of Gardnerella morphotype, and the absence of few white blood cells. You must rule out other pathogens commonly associated with vulvar vaginitis, including trichomonas, gonorrhea, yeast, and herpes simplex virus. Finally, trichomonas is a protozoal flagellate that can infect the vagina, skin ducts, and the lower urinary tract in women, and the lower genitourinary tract in men. This is sexually transmitted, and trichomonas is usually asymptomatic in men or may have non-gonorrheal urethritis. Women exhibit pruritus, a malodorous frothy yellow-green discharge, diffuse vaginal erythema, and red macular lesions on the cervix in severe cases. Diagnosis is made by saline or wet mount that shows motile organisms with flagella. Trichomonas may also be found on a pap smear. For the mucoskeletal infections, we talk about gangrene, septic arthritis, and osteomyelitis. It's important to aspirate the joint to obtain a culture and sensitivity for any specific joint infection. The joint requires local aspiration often, sometimes daily. In general, these infections should be treated by an orthopedist or infectious disease specialist. For osteomyelitis, the most common agents are Staph aureus, gram-negative bacilli, group B streptococcus. Patients should be referred to an infectious disease specialist and an orthopedic surgeon if osteomyelitis is suspected. Blood and infected bone should be cultured, and intravenous antibiotics are required, especially for initial treatment. Occasionally, treatment for chronic osteomyelitis will be completed orally in an outpatient setting. The most common offending organism is Staph aureus. We then look at infections of the central nervous system, and these include meningitis, systemic febrile syndrome, Lyme disease, and Rocky Mountain spotted fever. Meningitis for ages younger than 1 month, the common agent is usually a group B streptococcus, E. coli, Listeria, and miscellaneous gram-negative, miscellaneous gram-positive organisms. For 1 month to 50 years, it's mostly strep pneumonia, and meningitis, and H. influenza. That's rare. For age older than 50 years, strep pneumonia, Listeria, gram-negative bacilli, no meningiococcus. Meningitis requires hospitalization and treatment with parenteral antibiotics. There are both the viral meningitis as well as bacterial, with bacterial being more dangerous and can be spread easily. For the rickettsial diseases, systemic febrile syndrome has many causes. Rickettsial diseases include typhus, Rocky Mountain spotted fever, ehrlichiosis, and Q fever. Lyme disease is caused transmitted to humans by ticks. The tick must feed for 24 hours or longer in order to transmit the disease. Shortly after the bite occurs, the patient may experience erythema migrans in central nervous system and musculoskeletal symptoms. These include a target-like erythematous rash as well as joint pains. This must be confirmed by serologic testings, and effective treatment for most patients will be a short course of oral antibiotics such as doxycycline or amoxicillin. Some patients will require 3 to 4 weeks of treatment, and after treatment some patients still report nonspecific symptoms that can be very debilitating, which include persistent pain, fatigue, impaired cognitive function, and unexplained numbness. These patients may have no signs of active infection, but symptoms continue. These individuals may be diagnosed with a post-Lyme disease syndrome, and treatment is usually symptomatic. Reoccurrence of symptoms often represents a new or co-infection of other organisms. So don't miss those new tick bites that may cause Lyme disease in a patient that has already tested positive. Rocky Mountain spotted fever is caused by bacteria that's transmitted by the bite of wood and dog ticks. It occurs most commonly in the middle and southern Atlantic states and in central Mississippi Valley. However, it does occur throughout the United States. Symptoms include influenza-like prodrome, followed by fever, chills, headache, myalgias, and restlessness. A red macular rash appears on the wrists and ankles and spreads centrally. It appears between the 2nd and 6th days of the fever, and onset occurs 2 to 14 days after the tick bite. Again, the treatment includes oral antibiotics such as doxycycline and amoxicillin, sometimes often requiring hospitalization. So, with all these different disease and antibiotics, we also, not only do we have to look at the bacteria that's causing these symptoms, we also need to look at patient variables. For geriatric patients, these patients are at increased risk of infections, and their infections are often more serious than those of younger patients. Because of their low body mass, elderly patients may require a lower dose of antibiotics. They are particularly susceptible to the toxic effects of aminoglycosides. For pediatric patients, infants are also at increased risk for infection until their immune system is more mature. They're also greater risk for toxicity until their renal and hepatic function is adequate. Tetracyclines bind to teeth, and this is a big concern during pregnancy. Discolored tooth enamel may develop if tetracycline is given when the teeth are developing, and can result in retardation of bone growth. Fluoroquinolones affect growth of cartilage and developing bone. Use caution to ensure that an overweight child does not receive an overdose of antibiotics. Children younger than 12 years of age usually need more frequent dosaging and shorter dosage intervals because of increased metabolism and faster clearance. In pregnancy and lactation, many of the antibiotics are contraindicated. Pregnancy does affect the pharmacokinetics of antibiotics, and most antibiotics are passed into the breast milk. Again, the use of tetracyclines would be an issue during pregnancy or lactation because of the damage they cause to the developing child's teeth. Gender can also affect antibiotics. Certain antibiotics interact with oral contraceptives. Patients should always be told to use an alternative method of contraception when on antibiotics. Rafepine is the most frequent cause. Tetracycline and penicillins also have been implicated, and use extra caution in patients on low-dose contraceptives. This interaction is due to an alteration of the normal first pass mechanism seen with OCP therapy, and women are at risk as well for vaginal yeast infections when treated with an antibiotic. If this becomes a frequent problem, the patient may use over-the-counter vaginal antifungal creams when they are prescribed antibiotics as a prophylaxis. Patient education, you need to tell the patients to take all of their medication even if the condition improves. They need to call their provider if no improvement is seen within 2 to 3 days. You must warn the patient of the most common side effects of the specific antibiotic. Caution patients about adverse effects such as the vaginal yeast infection and C. diff colitis infection. Stop the medication if an allergic reaction occurs, and they need to notify the provider immediately. Most antibiotics should be taken on an empty stomach with a full glass of water 1 hour before or 2 hours after eating. However, not all antibiotics need to be taken on an empty stomach, and you need to look these up prior to prescribing. Lemon yogurt or other citrus flavors or chocolate masks the bitter flavor of many medications. Gum can be used to mask the aftertaste. This is often found with the erythromycins. You'll have a metal aftertaste, and gum can be used. Certain antibiotics may interfere with the effectiveness, again, of oral contraceptives, and all women should use an alternative method of contraception during the month in which the antibiotics are taken. Be very specific about when the patient should take the medication. Evenly spaced dose intake should be emphasized to maintain that therapeutic blood levels. Antibiotics should never be shared with others and kept and taken for another occasion of illness. Remember to explain to the patients that bacteria respond to different, are sensitive to different antibiotics, and if we don't treat appropriately, we will build up a resistance, and when the patient becomes ill, antibiotics may not be effective. Daily ingestion of yogurt with active cultures or acidophilus may prevent some of the diarrhea effects of certain antibiotics and may decrease overgrowth of yeast infections. Suggest this especially to your female patients. Instruct the patient to report if they're not getting better within a few days of administration of the antibiotic, or any rash, fever, chills, or any sensitivity to the drugs. This is, again, just a general overview of antibiotic treatments, and we will move on to specific classes of antibiotics in the next lecture.